Hey girlfriend, this is Jan James. Welcome to the Hope After Breast Cancer podcast, where women who have endured breast cancer learn to have fulfillment over frustration, clarity over confusion, and faith over fear. We tackle the issues that many of our sisters face after a breast cancer diagnosis, from brain fog to fear of recurrence, from menopause to sex after breast cancer. This is the place to learn how to have hope after breast cancer. So strap yourself in. Welcome to the Hope After Breast Cancer podcast. Hi guys. Oh, it's Jan from Hope After Breast Cancer. Gonna talk to you about something personal now. So this is Calligan, who's my gynae, women's health educator, and my friend, and I'm gonna tell the story.
Go for it. Go for it. I like this story.
You do? I didn't love it. So the first time I saw Chris, I had, hey Chris, I don't know how to explain this to you, but anytime we try to attempt sex, it feels like glass shards in my vagina. And so she's doing a pelvic exam. We all love the stirrups and everything. And all of a sudden, she hands me a hand mirror. And I was like, what do you want me to do with that? She said, come on down here. I was like, what? So, I'm in the stirrups, reaching, whatever. And she said, do you see this part right here that's this deep purple? Yeah. She said, well, that's vaginal atrophy. You definitely have vaginal atrophy. And I said, well, purple's my favorite color, but not anymore, I guess, right? So,
not in that area.
So that was a drag. So anyway, we're here to talk about, how do women know if they have it? What is it? And what kinds of solutions are there for that?
Yeah, no, this is a really great question. So atrophic vaginitis is really thinning of the vaginal vulvar tissue that happens when our hormonal levels drop. So naturally it happens through the menopausal phase as our ovaries production just of estrogen declines. It also happens very abruptly during chemotherapy and other types of cancer treatment. So atrophy is something that it can be found on physical exam. Sometimes we take a little swab too to confirm it, but quite often atrophy is like one of those things. Once you see it, you just know that this is kind of where it is. That tissue that's supposed to be plump with blood flow, hydration, starts to really thin down and just makes you more vulnerable to infections, to pain. The pain receptor sites start to just hurt. Yeah, all that kind of stuff. And some patients actually have no symptoms. So we see it on exam and we bring it to their attention as well.
And they have no symptoms. Oh, that was not me for sure. So anyway, so now what are the options that someone has if they
So thinking about kind of the pathology of this, it's or I guess I should start with, there's targeted tissue that has specific receptor sites in it. So the vulvar vagina has probably about 80 to 90% estrogen receptors, and then anywhere from 10 to 20%, every woman's a little bit different, of more testosterone or androgen receptor sites. So the atrophy is a decline in that. So one of the most common things, treatments for this is actually to replace that hormone to the targeted area. So that comes in the form of vaginal topical estrogens, DHEA, testosterone, that kind of stuff to it. With patients, especially with a history of breast cancer or anything else, it's really important if you're experiencing this to take a detailed history and just see if there's anything else that could be playing into this and what your risk factors are for treatment options.
Okay, so I was ER positive, PR negative, so then what? So I wouldn't want to have any estrogen solutions, probably?
Yes, especially as first-line treatment options. We definitely would go through and discuss other things that we can do. There's a lot of options now. So one of it's more of a vaginal moisture or hydration, and that is, do you know what hyaluronic acid is? Hyaluronic acid is something that we use in our makeups. It hydrates tissue. Have you heard of like lip fillers?
Sure.
Fillers, yeah. So it brings, it takes water and hydrates kind of areas. Well, now we can use this targeted therapy to vulvar vaginal. So it comes in the form of a suppository or a cream or a combination of both. And it really just hydrates the tissue. It helps when it's in, so it needs to be used frequently. So I'd say that might be a little bit of a drawback, but it really helps with the hydration and to make it to where you're not as susceptible to infections and to where things like intercourse are not as painful.
Okay, and then you talked to me about laser treatment?
Yes, there's lots of different laser treatment, radioactive frequency type treatment options that are available now that really help the skin, because this is more of a dermatological condition at this point. It's the vaginal vulvar skin. And so thinking about this skin with that, just as we talked a little bit about the face and anti-wrinkle or anti-aging things, this is, more of a medical diagnosis. I mean, I wouldn't put it in the same categories as far as elective or non-elective, but definitely something that we can do as far as overhydration and kind of some of the same things we do on the skin with the laser treatments.
Okay, so a bunch of the girls have done Mona Lisa. This is a highly non-scientific observation. It feels like it's a 50-50 kind of thing.
Yeah.
People are paying a lot of money for it, but like half of the girls come back, or one in particular who's a good friend said it helped for a little bit and then it was not good again.
So when we're not going to treat or address the actual pathology of it, of the decline of hormones, then anything that you're going to do is likely going to need ongoing upkeep.
Interesting. Okay. So Mona Lisa would help the tissue on a temporary basis. Well, that's not how they market it, of course. Well, I guess they do say that you would have to come in for 1 or 2 treatments a year or something like that, I think, as I
sounds
recall.
about right.
So, okay, what other options? Anything?
So
Atrophy?
going back to kind of the first line for me, I think it's really important to do an exam because it's all about kind of the level of, is this extensive and throughout the vaginal canal and vulvar area? That may need 2 or 3 interventions versus if it's a targeted 1 or 2 spots, or I mean, we were talking about
the vestibule. I was telling Chris I learned about the vestibule recently. And do you believe that part of the JJ is the vestibule? And I said, so if the door is closed, yes, that's what it is, yeah.
So really doing an exam, and I do kind of what's like a Q-tip point test of, does it hurt here, does it hurt there? And then once that assessment is done, really saying what's going to work best. And with women in general, we're complicated beings. There's normally not cookie cutter, one size fits all, one thing's perfect. It normally is an ongoing puzzle piece.
Right.
So even some of these treatment options, maybe they improve it 20 to 30%, and then we continue to add this on. This is another 40 to 60. Frequently we win the lottery and it's one treatment, and and that specific woman is good for with that, but a lot of times it needs reevaluation. And so I actually teach my patients to do vulvar vaginal exams, especially when we start treatment, because any intervention you're going to use, you're going to want to wait a good 5 to 7 weeks and continuing to look down there. It's a little bit like watching grass grow. Nothing happens, then huge improvements. So also giving each treatment option really the benefits to be able to work appropriately. I do want to talk about vaginal estrogens.
Okay.
So the American College of Obstetrics and Gynecology, they are kind of in the U.S. kind of the group of professionals and, that kind of do these reviews of all the different information that's available out there. And they actually make some what's called committee opinions or practice recommendations to really help us practitioners as we're just doing our day-to-day, offering patients treatment options and saying, listen, this is what is popular among practitioners. So I will say that in 2016, they actually came out with a committee opinion on vaginal estrogen and the use of that in women with a history of breast cancer. And it just was reaffirmed in 2020. So this is another thing that they've just, again, relooked at. We have several new studies that have come out where we were able to relook at the data and say, is this appropriate to continue recommending or not? So while it is not considered primary or one of the first line treatment options, that we should trial other treatment options, because just anything that we do in medicine, we try to do the least amount for the shortest amount of time with the least amount of complications. So I would say that, I normally strongly encourage my patients to at least trial some of the other stuff. However, if you've trialed that and have exhausted that, and this continues to be an ongoing issue, and this is life impacting for you, this is interfering with relationships and other things like that, then it absolutely is safe to use vaginal estrogen. So they've actually pulled the data, they've studied this, again, not as first-line treatment options, but they check serum blood levels to make sure that this is not systemic, that it's not being absorbed into the bloodstream, that it's staying localized to the vulvar-vaginal tissue. I think that's really important because it's all about our pharmacogenetics. So while I could talk about studies with thousands of women, if your pharmacogenetics processes that into your systemic system, then this could be more of a risk for you. And they found that there was no difference in patients that used vaginal estrogen cream in reoccurrence of breast cancer.
So that would tell us some trade name or brand names.
Okay, so that would be Estrace, is a bioidentical cream that's available.
Estrace, I used to throw stuff, remember? I used to throw stuff at the TV when those ads were on because I was so concerned that using that would be dangerous for our girls.
Well, I think we didn't have the data or information before.
Yeah.
Now I will say that
Wow.
even with the patients that choose to use vaginal estrogen, I always strongly encourage and promote involving their oncologist in this discussion because there's a lot that plays into this. How far, have you been cancer-free? What are your exact symptoms? What have we trialed in before? How much relief did we get? Did you get no relief with other therapy? Did we get higher relief but just had obstacles to it? Another thing that sometimes even before using a vaginal estrogen, so it's a more second or third line for me, is using DHEA in the form of intrarosa, or I like to compound it a lot myself because I normally include vitamin A and E in it. Suppositories, because that is not an estrogen and that cannot convert, and that really does hit those receptor sites.
Okay. I might be talking to you about the suppositories. Okay.
Yeah.
Hey, can you tell people how to find this? Because you said it's available
Yeah.
on the web.
This is actually something that you can even Google, and we can even add to this. So if you just go to committee opinion of ACOG, ACOG, and then the use of vaginal estrogen in women with a history of breast cancer.
So that's
gonna
awesome.
give
That's
this
a
to you.
great tool. Thank you. Okay, and we'll post it on our groups too. So thanks, kiddo. Appreciate that. Hope you got some value, guys, and appreciate you being here at Hope After Breast Cancer. Thanks. Girlfriend, thank you so much for listening to our podcast. I hope you found some nuggets to encourage you and give you hope. Make sure you subscribe to the podcast. You never want to miss an episode. And we'd love to know how we're doing, so please be sure to leave us a review. Until next time, this is Jan James encouraging you to remember there is hope after breast cancer. See you next time.